we're joined by Dr. Meishi Ma, who is a senior vascular fellow at the Vascular Surgery Fellowship Program here at the University of Florida in Gainesville. So Dr. Ma, thank you so much, and the floor is yours.
This is a right-handed 45-year-old male, otherwise healthy. He breaks horses for a living. He came in from an outside hospital as potentially acute on chronic, but concerns for ischemic right arm, had progressive sensory changes, mostly numbness and subjective coldness going down to his right hand. Did not have any sensations of pain. And he had some event where he hurt his hand, he hit it against something, and then had acute worsening of his symptoms. Did not have any personal or family history of coagulopathy. From a past medical history standpoint, just had asthma, was on Advair for that, no prior surgical history, vascular or otherwise, was a never smoker, and has an identical twin brother, which will become significant later, penicillin allergy. His vitals and labs were normal. His heart rate was in the 50s when he showed up. He was on a heparin drip when he arrived from the outside hospital. On physical exam, he had no cyanotic changes or tissue loss to his right hand. There was numbness and subjective coldness to that right hand. He was motor and strength intact. On his peripheral vascular exam, his other three limbs were normal. However, in that affected arm, he had no radial or ulnar signals. He had a palpable brachial just proximal to the elbow. We'll go through some imaging. So I guess we can ask questions. Does anyone see anything abnormal on the chest X-ray? I can give a hint.
Anything in the Q&A picking up what's there?
Not yet.
Okay, we can continue. This is the CT scan. There was a little blip right there, but this basically shows that the right subclavian axillary is open, brachial goes out right above the elbow, consistent with his clinical exam. And then there's no more opacification distal. This was his hospital course. He came in on a therapeutic heparin drip. He was taken to the operating room for a right brachial ulnar and radial thromboembolectomy. There was 4 milligrams of TPA that was instilled down his radial and ulnar arteries. The brachial artery had been opened transversely. It was primarily repaired. And then he was started on a 500 unit heparin drip after 4 hours after surgery. At the end of that procedure, he had a monophasic signal in that right radial. However, 6 hours later on his post-op check, there was complete loss of signals. The patient subjectively said that his sensation and symptoms were improved. There was no change in his motor exam. And then we had also done some pre-op testing that resulted that post-op day 0, where his ejection fraction was slightly diminished. On post-op day 1, overnight, he had some recurrence of his hand symptoms. His heparin drip was advanced to a low intensity heparin drip, and we obtained an arterial duplex given the loss of signals on his clinical exam. It showed that the right radial was occluded and the mid to distal ulnar was occluded, as well as a finding of thrombus, non-occlusive thrombus in the distal brachial on that right side. Overnight, however, his symptoms got better. He worked with BTOT. We found a monophasic right radial signal at the level of the wrist. So we did not take him to the operating room until the next day since his symptoms had gotten better. At that time, we took him for the sort of the full procedure. We did a right cervical and birth rib resection. So that was what we saw on that chest X-ray. There was a cervical rib. It's actually bilateral cervical ribs. So we removed the cervical rib and the first rib. We did a right subclavian interposition bypass graft. It was very short, maybe 3 centimeters long, using 8 millimeter ringed PTFE. And then we performed an angiogram prior to thrombectomy to see what his runoff was prior to pre-thromboembolectomizing him, and then opened up his antecubital cut down site and performed redo radial, ulnar, and brachial thromboembolectomy. When we cut down, we actually found that that area where there was the primary repair of the brachial artery was a little stenosed, and there was clot there. So we performed an ipsilateral or a vein patch angioplasty using ipsilateral basilic vein. So we'll kind of go through, I'll kind of go through some of this anatomy. I thought that this picture really demonstrated well how the anatomy of the cervical rib kind of fuses to the first rib. And then I'll show you some operative pictures that we have. So these pictures sort of demonstrate the underlying etiology for arterial thoracic outlet syndrome, which really only comprises about 1% of thoracic outlet syndromes. 2 to 3% are venous, and over 95% are neurogenic. And then this kind of shows you how this space becomes compressed. The pathogenesis of how people lose, get acute limb ischemia is they form in traumatic aneurysm at the site of compression with thrombus formation and then distal embolization of the thrombus. So these are pictures of our incisions. This is the antecubital cut down site for our thromboembolectomy. And then for our neck incisions, for arterial, we tend to do both infra and supraclavicular incisions. So these paraclavicular incisions demonstrated in this image. For our venous TOS, we use the infraclavicular incisions, and for neurogenic, we tend to use the supraclavicular incisions for access. So as you can see here, this is some of the clot that we pulled out. There was a lot of clot that we were able to pull out. Again, this is the segment of subclavian artery that we excised, and this sort of demonstrates that intimal injury and the nidus for thrombus formation, which then embolized down his arm and trashed his hand. And then this is the en bloc segment of the cervical rib, and this kind of demonstrates how it fuses to this first rib. This was our brachial artery cut down, our clamps for control, and this demonstrates the clot that we found at the initial brachial arteriotomy that we opened more longitudinally and then repaired with a vein patch. So these are the angios that we got prior to embolectomizing. The profundus brachii, you can see, is occluded here. And then this is the outflow down the hand. This is where the brachial artery sort of occludes right above the elbow, and you can see the radial arteries open. The ulnar artery was totally occluded. And then outflow into the hand was pretty poor. We had a couple of angios going down. We had to push some full strength dye in order to get anything to light up. And then these are our angios post-embolectomy. So you can see this area of spasm in the brachial artery. The outflow is a little bit more brisk going down the arm, marginally. But you know, the outflow did not look great. You can see his radial trying to reconstitute, but the flow sort of into the hand and generally in his forearm and hand were pretty poor. We attributed most of this to spasm on top of the fact that he had already previously trashed his hand and then failed a thrombectomy, suggesting that his outflow was not great. So at the end of the case, we were able to obtain biphasic signals in the radial. However, by the time we rolled out of the room, we no longer had that radial signal. We decided that his hand was pretty cold. We were going to see how it went, but this was basically going to be what he got. We started a 500 unit per hour heparin drip, again, 4 hours post-op. And then when we do these TOS or rib resection procedures, we get a post-op chest x-ray just to look for pneumo. And this is the pre-op chest x-ray. You can see the cervical rib here. This is the first rib coming around here. And then you can see on the post-op chest x-ray, no pneumo. And then also the now opened up space after resection of the ribs. On post-op day 2, after the second intervention, he was actually found to have right radial and ulnar monophasic to biphasic signals. He said that he felt like he was able to move his arm better. He worked with physical therapy and occupational therapy, was given exercises. His anticoagulation was advanced to low intensity drip, and his symptoms were pretty minimal. However, we wanted to see what the results were on a duplex, and arterial duplex obtained that day showed pretty severe digital ischemia in the right arm and hand. And he also had absent waveforms at the right radial and ulnar arteries. The proximal bypass was patent. On the second day after his second surgery, post-op day 2 after his second surgery, he was advanced to a DOAC and was discharged from the hospital. So we saw him a couple weeks ago. Symptoms have returned. So he has the same symptoms that he had going down that hand, numbness in the hand and subjective feelings of coldness. His right upper extremity duplex is unchanged from his post-op arterial duplex. The bypass is still patent proximally. He is compliant on his DOAC, aspirin, statin, and Pletol. He does not have any tissue loss or any at least visible signs of ischemia or cyanosis in his fingers, though again, severe digital ischemia in his right hand. At this time, you know, we're telling him to protect his arm, make sure to not injure it. He is right-handed, and again, he works with horses, so trying to prevent him from getting any sort of occupational related injuries. And then we're going to bring him back in 6 weeks to plan for the left side. He is at this time asymptomatic on that side. And then we also want to bring in his twin brother for evaluation of arterial TOS and the presence of a cervical rib.
That was a great case. Thank you, Dr. Ma, for that presentation. Obviously a rare phenomena, but all vascular surgeons probably at some point will either manage or refer one of these patients. A few questions before we open it to the floor. In that first post-op night with the change in signals, understanding that the patient's clinical symptoms weren't severe, but with the loss of was the anticoagulation intensity increased in that moment, or was it just sort of resign ourselves to let's look at the imaging the next day? We know a definitive repair is coming in the next day or two, so them stand down. Was that sort of the initial thinking? And then second question as a follow-up, given the hindsight, do you think it was truly the stenosis and thrombus at the anastomotic site and a technical problem, or also the was he chronically embolizing that distal forearm runoff? Because with his current situation, he does not have it really doesn't have any distal reconstructive options, it looks like. And now you're going to be relegated to sort of using first, second, and tertiary medical management of of that hand.
Yes, so for the first question, yes, that was our thinking, was that he was gonna get a big definitive surgery in a couple of days, and so we did not rush him back to the operating room. He had had clinical improvement of his symptoms, and then so it was sort of this waxing and waning picture. We didn't know if it was just too cold in his room. We got a bear hugger, we tried to keep his arm warm, and then he would say subjectively that maybe he felt better, whether it was psychosomatic, whether it was, a trashed outflow, whether it was continued embolization down his arm. I think that he had a lot of factors that could have contributed to his sort of unclear postoperative picture. And then what was your second question?
Oh, just in terms of what you think the failure was due to. Was it
Yeah,
technical, or would you think it was just chronic embolization and no runoff, or just the combination?
yeah, when we talked to him, like, what was the true time course for how long you had symptoms? Because originally when he came in, he said it was like 3 to 4 weeks, and then he sort of changed his answer, and he was like, maybe it was 2 months. And then he had this other event where he sort of injured his hand, and then the symptoms acutely got worse. I think that he had been chronically sort of trashing his hand, and he had developed some form of collateralization because he was tolerating his extremely poor outflow pretty well, for us to be concerned that it was an acute process. That's why we didn't really rush off to the operating room the second time as well, because we thought that this was more of an acute, a more chronic problem as opposed to acute. And so I don't know, he was one of those guys. He's young, healthy, and I don't think that his vigilance was necessarily that high about thinking something was going on. And his wife was actually the one who encouraged him to come to the hospital. So the story was one thing when he showed up, and then sort of changed over the next few days.
I think we're definitely all familiar with that scenario. Thank you for that. I'm going to leave the remainder of the discussion and closing remarks now to Dr. Patel.
Hey, so another great presentation, challenging because you do everything right and you still leave the OR somewhat defeated. So my questions for you, 2 questions. Number 1, any role of potentially doing a thoracic sympathectomy on this person that potentially has digital ischemia or chronic pain there? And then number 2, you said you're going to work up the twin brother. What sort of workup would that consist in terms of how you guys work up arterial, venous, or even neurogenic thoracic outlet? And then specifically for the twin brother, what is your threshold to offer him a surgery if he is otherwise asymptomatic?
Okay, thank you for those questions. For the role of thoracic sympathectomy, he actually wasn't having pain. He was just having numbness, paresthesias going down that arm. And I was not the one who saw him in clinic, but he was able to sort of tolerate those symptoms. He was not complaining a lot from those. And as for the twin brother, I actually didn't ask what his twin brother did for a living. We were thinking that a lot of this could have been sort of repetitive motion injury from him breaking horses and being right-handed. His left arm was totally asymptomatic, and from what I understand, his brother had no symptoms either. And so I think that given the fact that he is young, he already has, pretty poor outflow of that right arm with limited to no reconstruction options, the threshold would be much lower to offer him repair for that left side, despite the fact that he is asymptomatic. And then because we don't want to obviously wait until something bad happens and then leave him with 2 bum arms. at 44 years old, 45 years old. And then as for the twin brother, just starting with a chest X-ray to see if he even has the, cervical ribs.
Thank you very much.